Today, it's our pleasure to spend some time with Dr. Sacha Bhatia. He's the FM Hill Chair in Health System Solutions at Women's College Hospital in Toronto, studying the appropriateness of care, in particular digital health innovations and health service design to influence policy that will improve delivery of care and models of care for patients across Canada. Dr. Bhatia, welcome to our program.
Thanks for having me.
Absolutely. Virtual care, boy, oh boy, are we ever talking about that a lot in the arthritis community over the last 12 months. And it's very interesting, obviously, at the onset of the pandemic, if people didn't really understand what we meant by virtual care, they do now since they've experienced it. Some of our patients have been experiencing it for a decade now, especially ones in Northern Canada and rural and remote areas. But it is now part of the mainstream. And I think overall, our patients have had a pretty good experience with it. And certainly that has come out in a national survey that we've recently conducted and that we'll be publishing the results of. I think now we're starting to sort of turn our attention to what's next and how is this going to be integrated virtual care and the experience that we've all had in the long term. And I know this is something that you focus on in your research, but also something that you delivered in the form of a presentation at the CRA's annual meeting, online virtual meeting this year. And we're really interested to hear our audience to hear maybe some of those key takeaways from that presentation and how that will apply to their lives living with osteoarthritis or inflammatory arthritis.
Great. Well, thanks so much. And again, thank Kelly for having me on. I think, it's funny because prior to the pandemic, I've been researching virtual, care, digital healthcare for a while. And one of the biggest challenges that was always, people always said is, well, are doctors and patients really going to do this? Are they really going to engage in virtual care? And I think the answer now is absolutely. We had this natural experiment where in the research that we did, we found that during the first wave of the pandemic, over 70% of the care delivered in Ontario, during that first wave was virtual. And it meant that, although there was a drop in outpatient care that was provided because people didn't really know what was going on and they wanted to protect getting sick, the reality is we actually only had about a 15 to 20% drop in overall care visits, which meant that virtual care really stepped up and was a bridge and was a way for many patients, particularly those with chronic diseases, to get care, to get their medications refilled, to be able to talk about symptoms, to be checked in by their physicians, and potentially move their care journey along. Now, what was the big change? Prior to the pandemic, less than 1% of the care in most provinces was provided virtually. And the big change, and this is sort of the central theme of what I talked about at the CRA conference, was this idea of the cost of. So what do I mean by that? I mean that there always is an inherent cost of patients coming in to see a doctor like myself in person. But prior to the pandemic, that cost was all put on the patient. So what do I mean? I mean that if you think about it, if you have one of your listeners who may have an inflammatory arthritis, like they have, rheumatoid arthritis as an example, and maybe they're a mom, and maybe they've got 2 kids, maybe they're working, at a grocery store, or they're working as an essential worker. and they've got to go see their rheumatologist. Think about all the things that they have to do to get that appointment. They got to find childcare for their kids. They've got to find, probably they've got to take time off work, find somebody to cover for them. They've got to drive down to the hospital or the doctor's office. And if it's in a city like Toronto where I practice, that's not necessarily an easy feat. And then they've got to like wait, however long, sometimes up to an hour or more, to see the doctor for a 15-minute appointment, right? I mean, there's a lot of inherent costs for busy, stretched people. But COVID changed that. What COVID did for us was it actually changed the costs of in-person care and balanced it on the health system as well. Because in COVID, suddenly as a doctor, I have to worry, one, are patients who come into the hospital potentially going to get workers sick? And not just doctors and nurses, but our front desk staff, our cleaning staff, the people that work at the Tim Hortons in the cafeteria. All of those things, are risky. Other patients in the waiting room. I have to worry about PPE. So then I have to think, at the beginning of the pandemic, PPE was expensive and scarce. So every time a patient came in, we have to change gowns and gloves and all that kind of stuff. That has material costs, particularly for doctors' offices, not necessarily in hospitals. And then finally, there's a capacity question, which is, at the end of the day, I could only bring so many people in at a time. And so every person that I bring in person means there's another person that doesn't get to come in and do an in-person visit. So I have to triage. So it has been this rebalancing of the costs of in-person care, or the costs of contact, that I think has really driven much of the adoption of virtual care as a potential way of mitigating that cost. So that's kind of the thesis that we've been running with.
So I've got a question then, as it relates to the costs of care for the patient. The one other thing I would add, certainly for people living with an inflammatory arthritis and sort of serious, severe disease activity, is the whole issue of mobility and the difficulty getting to the appointment. And if you add all of the things up that you mentioned, there's also an emotional cost for the patient. And I'm wondering what your research can tell us about that emotional cost, because I'm thinking that person who's gone through all of those steps, all of those obstacles that you said to get to that appointment, you can't expect them to have their A game for those 15 or 20 minutes. And that the qualitative aspect of that very important in-person meeting with their specialist, after all the stress that they've had to go through and possible physical challenge and pain, and then to sort of be able to turn it on for 20 minutes and then and compare that to they've been at home, they haven't had to go through all these hurdles. Does that mean it's maybe a better experience, not just for the patient, but for the patient and the doctor?
I think there's some evidence that would suggest that. And so let's start with the positive. During the pandemic, being able to provide care that goes to the patient as opposed to care where the patient has to come to us can have some psychological and practical advantages for the patient. Here's a few. Many of my patients, in the pandemic were afraid to come down into downtown Toronto because they were afraid of getting COVID. And on the other hand, they were also, they also have heart conditions. So they don't want to, come on down. They don't want to miss their appointment with their doctor. So by doing this, we gave them the best of both worlds. They got to connect with their specialist, who was able to assess and reassure them or suggest a treatment course or change medications, while at the same time not causing the psychological stress of them feeling that they're going to come down into where there's a COVID hot zone. So that was one. I think the second is practical, which is when you have a patient like I have a lot of patients who are essential workers and were working through the whole pandemic. And for them, there's a real material cost for them to, take time off work to come in and see you, like and so for them, and then I also, because I'm at Women's College Hospital, my practice is still over 50% women. Many younger women have childcare concerns. Many younger women have, and many others have other, caregiving concerns. If you're an older woman, you might be taking care of a husband, as an example. For them, taking all that time off to come downtown and come away from their work or other obligations was really hard. So when I could just give them a call and or get on a Zoom call or whatever and be able to connect with them, they really valued that because it didn't inconvenience their day and it didn't require all of the organizational gymnastics that sometimes goes into having to organize your life around appointments. And so, yeah, I think that there is real value to that. And just to add, I think the benefit on top, many people worry about the equity piece of digital care. Yeah. They worry that when people, if people have, don't have access to computers or don't have access to technology, that they will be disadvantaged. I will turn that around and say, many people that are, vulnerable, don't have time, and they have childcare responsibilities. They can't work from home. They have many challenges in just getting to doctor's appointments. By making it easy for them, by either me calling them on the phone, oftentimes, I can connect to them in a way that suits their life. And actually, we saw a much lower no-show rate among our patients during the pandemic than we did prior. So I actually think if done the right way, you might even be able to narrow the equity access gap by removing barriers that prevent patients from coming into appointments.
One of our public policy areas that we focus on is health inequities. And it really is going to come down to the integration that, yes, in the last 12 months, we've all been scrambling because we had to deliver care in this incredibly pressure-filled environment. And we did the best we could, and virtual care was obviously a very valuable tool.
Yeah.
Now what, right?
Yeah.
Like how are we going to adopt? Because I think the other, before we look at the health inequities, just the final word on costs is there's also the health system costs and potential savings that virtual care potentially can offer governments. And so governments, and we know it's not the federal government, it's the provincial governments responsible for delivery of care. They're now all running around going, okay, what is this going to look like moving forward?
Yes.
How are we going to adapt our models of care to include virtual care? Something as simple as we've been talking about, that in-person, that clinical visit, what is that going to look like in the future? And when we talk about health inequities, how do we make sure no one gets left behind?
Yep.
I agree with you that there's a very positive potential here, but obviously for the marginalized, whether it's low income or English as a second language or low health literacy or low digital literacy or no access to technology, these are all barriers that the governments and the healthcare systems, we're going to have to look at very, very carefully. Talk to us a little bit about integration. So what does that look like? Because obviously we get asked the question, we're not experts in technology, we're experts in arthritis, and we're trying to arrive at this intersection. We get asked about integration, and boy, oh boy, there are a lot of serious issues there that have to be addressed and have to be addressed fairly quickly.
Yeah.
And obviously, we hope it's not just experts like you, but it's people like us who are also at the table talking about it.
Yeah. Yeah, I think a great question. So you're absolutely right. It's difficult to compare what happened in the pandemic to what came before and came after, because we weren't really talking about virtual care versus usual care. In many cases, which was virtual care versus no care. So, and that's a very artificial sort of environment. What I do think has happened is we have changed people's perception of what virtual care is, which in my mind is just care. Like I think we will get to a point where, I hope soon, where we will drop the just be care. It's just care being delivered in different ways. And the would use, which gets thrown around a lot, but maybe not quite like this, is in banking. So the thing about banking, when we started the internet banking and the online banking and the telephone banking, is we all called them different things. We said telephone banking and internet banking and online banking and mobile banking and then in-branch banking. And eventually along the way, the first word of that all fell off, right? And now it's just banking, right? And if you talk to people, it's like they inherently know what service, what modality of banking they need to service. Like, for example, if you have to take money out of a machine, you have to go to an ATM, right? That if you need to pay a bill, you can pay it in the branch, but you can also pay it on your computer. You can pay it by mobile. You know that if you need to deposit a check, you could go to a branch and go to an ATM. You have to go to your own branch's ATM, or you can deposit it by your phone. And you know that if you need to speak to a financial advisor, you need to book an appointment. The point being is, these are things that I'm sure when I speak to your thousands of listeners, they will intuitively be able to follow what I'm saying. And they'll say, yeah, that totally makes sense. And that didn't happen overnight. That was something that happened slowly. And what it really was is, it's not about, and that's the real point here. It's about, how do we redesign service delivery such that it is the right service with the right underlying technology for the right patient at the right time. So